Today, our speaker is Laura Crack from the Edwards Group. And a little bit about Laura. She did her undergraduate degree in biological health sciences at Bishop's University, which I just learned is in Sherbrooke, Quebec. She moved to Calgary to complete her master's in kinesiology here with Dr. Doyle Baker, and is currently in the Edwards Group looking at bone loss and fracture risk following spinal cord injuries. So, Laura, whenever you're ready.
All right, thank you for the introduction. Thanks everyone for being here today. As mentioned, I'm part of the Edwards Lab. If you're expecting a heavy biomechanics talk, it's not the case today. I do more of the clinical side of things in the Edwards Lab, but hopefully everyone will enjoy nonetheless. So today, as mentioned, I'm going to talk a little bit about bone loss and fracture risk following spinal cord injury. There'll be a little bit of qualitative work related to patient priorities and some more quantitative work investigating some treatment options. Spinal cord injury leads to substantial bone loss below the level of neurological lesion and some, but less, bone loss at anatomical locations above the neurological lesion. This major sublesional bone loss is a well-known secondary complication, and research demonstrates that losses are greatest at the proximal tibia of the knee with about a 50 to 60% loss of bone content. Secondarily, at the femoral neck of the hip with about 30 to 40% of bone mineral content lost. And this bone loss typically plateaus about 2 years following the injury. Bone loss is mainly caused by mechanical disuse, and this is supported by research in paraplegic and tetraplegic individuals. So for those who are less aware on this topic, someone with a paraplegia would have motor functioning loss in the lower body versus tetraplegia. You'd have typically loss of motor function in both the lower and upper body. And we see that this the majority of bone loss does follow this trend. So those with paraplegia have most bone loss in the lower body, and those with tetraplegia would have corresponding bone loss in both upper and lower body. Bone loss above the level of neurological lesion, bone loss below the level of neurological lesion is a little bit less well known, but still present. It stems from a combination of hormonal and neurogenic factors. However, for today's talk, I'm going to talk more about the bone loss due to mechanical disuse. Mechanical loading places strain on the bone, and the bone responds to strain magnitude, distribution, and the frequency and number of loading cycles. The skeleton is able to direct bone formation to anatomical locations that experience high levels of mechanical strain by adapting its remodeling process. As many of you are likely familiar with, bone remodeling is a coupled homeostatic process. You can see here, hopefully, can you see my cursor? Yeah, this is a basic multicellular unit, which includes about 10 osteoclasts and a few hundred osteoblasts. You may have heard osteoclast cleave bone, osteoblast build bone, or some kind of variation of this. So the osteoclasts act similar to macrophages, and they cleave the old or aging bone, and then the osteoblasts are anabolic and lay down new bone. Without going into too much detail at the molecular level, the optimal amounts of mechanical loading will lead to maintenance of healthy bone through this remodeling process. Drastically reduced amounts of mechanical loading due to immobility during spinal cord injury, on the other hand, creates an imbalance in the remodeling process such that the osteoclastic activity is going to substantially exceed osteoblastic activity. This is going to lead to a rapid decline in bone mineral content and density following injury. This, of course, then can lead to the diagnosis of secondary osteoporosis, as well as increased risk for pathological fracture in this population. Therefore, bone loss prevention immediately following spinal cord injury is a research priority. The subacute and acute periods following spinal cord injury are a particularly interesting and challenging time in the clinic for patients. So when patients come in with a spinal cord injury, often their first concern is, are they going to be able to walk again? An accident that causes a spinal cord injury may cause other injuries as well. So they might be nursing other fractures in the body. Spinal cord injury can have many systemic effects. For example, it can affect the cardiovascular system, the renal system. So there's a lot of priorities to juggle for these patients. And in some cases, the probability of future bone loss might not necessarily be the highest priority for the individual. So it kind of creates this paradoxical issue where the patients have many clinical priorities to juggle. And we know that it's a good time to treat for injury prevention. But again, there's a lot going on. So not injury prevention, bone loss prevention. So it's a difficult time for these patients. With that, we want to remember that when we're talking about trying to develop standard of care in this clinical population, we want to try and find ways to reduce the burden or reduce the level of how cumbersome the treatments are during this time. For those in the chronic phase of spinal cord injury, on the other hand, treatment options for bone building must also be a research priority here. Most patients in this phase will already be diagnosed with secondary osteoporosis, so we want to work on bone building. Finally, it's important to develop clinical education tools to ensure that people with spinal cord injury understand their long-term risks and their treatment options in order to provide or serve really well in terms of patient-centered care. So I've rearranged these research priorities a little bit in order to outline the discussion today. So today I'll outline 3 projects that sort of contribute to each of these research priorities. They don't necessarily fully answer these research priorities, but I'll address a little bit on each one. The first study discussed today was completed to investigate and describe current knowledge levels related to bone health following spinal cord injury. So this is a bit of a preliminary step towards addressing this larger research priority. This is a qualitative or descriptive study in nature. If that's not your favorite, don't worry, I will get to more quantitative studies in the second and third today. So the second study discussed today is part of a clinical trial investigating a pharmaceutical treatment option in that acute phase. So again, addressing bone loss prevention in the acute phase. And the final study I'll talk about is currently ongoing, and it's looking at a pharmaceutical treatment for bone building in the chronic phase of spinal cord injury. So as I mentioned, I'll start off with the knowledge and awareness assessment of bone loss and fracture risk after spinal cord injury. This is that more qualitative study in nature. So in the introduction today, we've seen that bone loss and osteoporosis is a concern following spinal cord injury. But I want to step back for a moment from spinal cord injury population. Many will know that osteoporosis is a common health concern among the aging population in both sexes, perhaps a little more predominantly among females following menopause. In these non-spinal cord injury populations, educational programs exist discussing elements of bone health such as calcium and vitamin D intake, as well as exercise. These programs have been found to effectively increase osteoporosis knowledge, lead to modified lifestyle behavior, and decrease fracture risk in these non-spinal cord injury populations. An established osteoporosis knowledge assessment tool has even been validated for adult women, indicating that there's a priority for osteoporosis education and knowledge in the healthy aging process. However, there's currently no standard education program for bone loss following spinal cord injury, nor a specific population-specific tool for assessing knowledge in this population. Therefore, the purpose of the first study today was to explore current self-reported education and awareness levels related to bone loss and fracture risk among those with spinal cord injury. Again, this doesn't address that research priority in its entirety, but it's sort of a preliminary step to look at descriptive trends of education in this population. A convenient sample of 138 adults with spinal cord injury completed an online survey within Qualtrics, which is just the secure survey platform used here at the U of C. The survey was distributed via social media and partnering organizations worldwide who work with people with spinal cord injuries. So this included some parasport organizations. It included different national organizations related to spinal cord injury around the world. And that survey distribution began in February of 2021. Respondents were asked to self-report several personal characteristics, as you can see here, as well as some information regarding their spinal cord injury. This was done as part of a larger study related to secondary health outcomes following injury. And so within this larger survey, respondents were asked a series of questions pertaining to bone health and bone health education, which I'll highlight over the upcoming slides. Just to look first at the sample. The sample included 62% males and 36% females. It's not uncommon to have a higher proportion of males in spinal cord injury research because this is reflective of real world numbers. The ages range from 18 to 74 years, and we did specify with the survey that you needed to be a minimum of 18 years to complete it. The sample was primarily white from either North America or Europe. This was likely based on survey distribution. So within the social media channels, we were able to reach globally, for example, using like Reddit threads specific to spinal cord injury. But in terms of finding organizations that helped us distribute, I just was limited in that there needed to be an online presence. I needed to sort of be able to find them in English and communicate with them. So this likely influenced the distribution of the survey. Most respondents had some sort of post-secondary education and spoke English as at least one of their languages in the home. So this isn't, a validated tool for measuring literacy in the group by any means, but it does provide a bit of an indication that likely the survey was well comprehended by the respondents. Most respondents had been living with their injury for over a year. In terms of level of spinal cord injury, the list here is in anatomical order from highest to lowest for those who are unfamiliar. So you can see that the distribution was fairly good, but most of the slightly higher in the slightly larger numbers in the anatomically higher locations. Completeness of injuries were about half and half. For those who are unfamiliar, a complete injury is indicative of no nerve communication below the site of injury. So that would mean no sensory or motor functioning remains below the site of injury. Whereas in an incomplete, there might be some sensory and motor function retained below the level of neurological lesion. Most participants had not experienced a fracture since their spinal cord injury, but about 33% had experienced one or more fractures. We also had the participants give us a description of how the fracture occurred, and we had two researchers independently classify these as either high energy or low energy fractures. So to give an example for context, one of the descriptions was a wheelchair moving at a regular to slow speed and a foot getting caught between the wheelchair and a door frame or a wall, for example. So this would be a low energy fracture. It's something that we wouldn't, it's not a high impact, and we wouldn't expect a healthy bone to necessarily fracture under this circumstance. So approximately 3/4 of the fractures were classified as such. And for context, this is what we would expect to see in a spinal cord injury population. Jumping into the bone health education side of things, based on survey results, we saw that just under half of the participants had either never heard of bone mineral density or only vaguely recalled bone mineral density being discussed during their hospitalization or rehab. On the other hand, just over half either clearly recalled bone mineral density being addressed in some fashion during their rehab or hospitalization, or they had a designated group or individual education session on the topic. Based on a series of ordinal regressions, there was no impact of sex, age, location, or level of education on the BMD education received as outlined in the 4 categories on the previous slide. There was the duration of spinal cord injury in years was a significant predictor. So the odds of reporting a better level of education as shown on the previous slide were just slightly higher with every increased year of a spinal cord injury duration. Level of spinal cord injury was not a significant predictor, but completeness was. So those who had complete injury had about double the odds of reporting a better level of education than those with incomplete injury. When asked if participants knew that low BMD can be a secondary risk following spinal cord injury, 68% responded yes, and 32% believed that this was not true. There were a number of different knowledge assessment questions related to possible contributors to low bone mineral density and possible consequences of low bone mineral density. I'm not going to walk through every single one of them because everyone will leave the room, but I just wanted to highlight a general trend that sort of about 50% of the participants were pretty successful in answering these knowledge-related questions. 30% were fairly successful, but maybe had some room for improvement, and 20% were consistently unable to correctly answer the knowledge-related questions. When asked if they knew their own bone mineral density, 75% of the participants did not know their own BMD, despite this being an important risk factor in this population. When asked if they believed their knowledge of bone mineral density was adequate, only 30% of participants believed this to be true, while the other 70% felt it was inadequate or they were unsure. In general, about 3/4 of the participants said they were concerned about bone mineral density. They were interested in learning more about prevention for bone loss, and they were interested in learning more about treatment options. So this is indicating that overall, I would say this is an expressed patient priority based on the sample that we had. So just to kind of synopsize this first study a little bit, wanted to touch on that most participants knew that low bone mineral density is a secondary complication after spinal cord injury. Overall, pretty successful at identifying contributors and consequences of low BMD. But as I said, about 20% consistently could not answer the knowledge-related questions. So certainly some room for improvement there. Approximately 75% did not know their own bone mineral density. And because this is an important risk factor in this population, I think this should be a priority in order to provide better patient-centered care. Most people, like we saw, were concerned about their low bone mineral density and were interested in learning more. So again, I think this gives us good indication that based on this sample, there is some patient priority in this knowledge. And just wanted to remind us that these trends are mostly from sampling of North America and Europe. So because healthcare and health education is very different globally, of course, these trends are limited in their generalizability. So that was it in terms of the more qualitative work. So I'll jump now into the more quantitative work. This first study is looking at a pharmaceutical treatment type for bone loss prevention in acute spinal cord injury. And this is related to zoledronic acid. So for those who are not too familiar with zoledronic acid, it's a currently utilized pharmaceutical treatment for osteoporosis. It's in the category of drug known as bisphosphonates, and it is administered via a once-yearly intravenous infusion. When we think about treating osteoporosis or treating bone mineral density, we kind of have two ways. If you think back to that basic multicellular unit, we can either increase bone mineral density by slowing resorption of bone or slowing osteoclastic activity, or we can increase bone mineral density through anabolic or increase osteoblastic activity. The class of drug bisphosphonates, they are anti-resorptives, so they impede the action of the osteoclast in order to increase that BMD. Our lab has published 2 papers related to this clinical trial in which 60 participants with acute spinal cord injury were randomized to receive either zoledronic acid or placebo. Today, I'm just going to focus on the first year of this study, and we won't worry too much about the second year. So this is quite a complex table. Don't worry too much. Pulled from the first paper that was published for this clinical trial. Some of you may have previously seen Dr. Edwards speak to some of these results. So again, I'm not going to focus too heavily on this. I just wanted to highlight that these results demonstrate that in general, a single infusion of zoledronic acid attenuated bone loss at the spine, hip, and knee for the first year of this clinical trial. Mainly today, I will focus more on the second paper that was published. And the primary purpose of this secondary post-hoc analysis was to more thoroughly characterize changes to bone mineral and strength at the hip for those receiving the zoledronic acid treatment. And we used 3-dimensional analysis techniques here. The secondary objective was to examine the influence of ambulatory ability, which we'll touch on in the next few slides, on these treatment-induced changes in bone. So clinical trials do have quite complex methodology. So this is a bit of an oversimplification just for talking about this secondary analysis. But we had these 60 participants randomized into the 2 groups. Again, it was predominantly males, but like I said, that's not uncommon in spinal cord injury research. In terms of the analysis I'll go over today, they received a CT scan and an ambulation assessment at baseline. They were reassessed at month 6 and 12. And then we used some finite element analyses in order to analyze the results here. When addressing the primary objective of this secondary post-hoc analysis, results demonstrated a significant treatment effect on finite element predicted bone stiffness and strength, whereby bone strength at the hip was reduced by an average of 25% after 1 year in the placebo group, but this loss was mitigated to about 10% for those in the zoledronic acid group. We can see here, yeah, I still see my cursor. The placebo group, this is a representative strain distribution model. So this is not an average over the placebo group. This is one individual that we found representative of the group. And so you can see here, based on the strain distribution model, there was quite an increase in strain at the femoral neck and trochanter at 12 months compared to baseline. Whereas in the ZOL group, again, this was one individual, not an average value, but we can see that these changes were mostly mitigated in the zoledronic acid group. So to touch on that second post-hoc analysis objective, we wanted to look at ambulation status because mechanical disuse is a major concern, of course, in this post-spinal cord injury population. And so degree of ability to walk or ambulate can play a crucial role in understanding the severity of osteoporosis and the treatment in this population. The walking index for spinal cord injury, or Whiskey scale, is used clinically to indicate one's level of ambulation after injury. This is an ordinal ranking scale, and you can see a score of 0 would be unable to walk in spite of all supports. A score of 20 would be able to walk normally without any supports. And scores in between can range, including different types of assistance, so like parallel bars, walker, cane, for example. They include different types of braces, as well as different level of assistance from another individual as well. These graphs here are the Whiskey scores over the first year of the clinical trial. So you can see in green, this is the zoledronic acid group, in red, the placebo group. The thin lines are the individual data. It's noteworthy that at the bottom of each of these graphs, that line is darker because over 10 individuals in each group started at a Whiskey score of 0 and stayed there throughout the first year. So these lines are representing a number of individuals. There are some in each group that started with a bit of a higher scale and some that were able to reach close to or a score of 20. Overall, the two groups were quite similar. So a significant treatment group effect over time was present for all the CT-derived bone mineral properties. So you can see this in these graphs. Again, the green represents the zoledronic acid group and the red is the placebo group. So these thin lines show, in general, with different constituents or compartments of bone, that zoledronic acid mitigated losses in bone over the year of the trial. Because I wanted to sort of create a visual for change in ambulation status over the course of the clinical trial, the Whiskey score, the change in Whiskey score over the year has been binarized here. The number is a bit arbitrary. I picked a score of 4 because it was the 75th percentile of change in the group. But really, I just wanted to have a binary visual for you. So in a few of the bone outcomes, the change in Whiskey score was a significant predictor of the bone outcomes. So in here, I have represented femoral neck trabecular bone mineral density and trochanteric trabecular bone mineral density. So in both these cases, there was a significant effect of the treatment and a significant effect of change in ambulation status. On the other side here, for graphs C and D, there was still that significant treatment effect. And while the graphs visually look similar, the change in Whiskey score was not a statistically significant predictor of the outcome variables. Notably, improvement in ambulation ability, or that change in Whiskey score, did not significantly affect finite element predicted stiffness and strength. So these results suggest that while some compartmental constituents of bone were affected by the change in Whiskey score, the effects were not great enough to have an influence on that composite variable of bone strength. So just to finish up for this study and sort of translate back to clinical context a little bit, we saw that a single infusion of zoledronic acid in acute spinal cord injury does attenuate losses in proximal femoral strength for at least 12 months, regardless of one's ability to ambulate. The original publication for this clinical trial suggested that the treatment is safe and effective. It's beneficial in the acute phase due to its once yearly method of treatment. So again, like I touched on earlier on, that acute phase of spinal cord injury is really complex. So having that single dose annually is a positive component for zoledronic acid. And therefore, these results together suggest that it could be a possible standard of care for acute treatment in spinal cord injury. The final study I'll touch on today addresses that last priority of bone building during chronic spinal cord injury. So today we will talk about romosozumab injections as a possible treatment type. Dr. Edwards and his colleagues had previously done some work in the chronic spinal cord injury population looking at teriparatide treatment, which is an anabolic bone building agent. The work had suggested sort of limited effectiveness, which is what has taken us to this next step of looking at romosozumab. For those who are not familiar, romosozumab is a newer osteoporosis drug. It's a human monoclonal antibody with both anti-resorptive and anabolic effects. It binds to sclerostin, which is an inhibitor of bone formation. When the drug binds to sclerostin, it prevents sclerostin's inhibitory effects, leading to bone formation. So I like to think about it as like the double negative making a positive. So you're inhibiting an inhibitor, leading to increased bone formation. This is the same pathway through which mechanical loading impacts bone formation. So romosozumab is sometimes referred to as exercise in a syringe. It's currently used as a treatment option for postmenopausal osteoporosis. And we are currently investigating, of course, its efficacy in treating secondary osteoporosis during chronic spinal cord injury. More specifically, the purpose was to look at this treatment type with monthly romosozumab injections on the impact of bone mineral density in women with chronic spinal cord injury and an inability to ambulate, so close to or whiskey score of 0. So 12 women who met these characteristics were recruited for this clinical trial. They have a mean age of about 45 and an injury duration of about 15 years. Again, this is go backwards. This is a bit of an oversimplification of methodology for a clinical trial. But at baseline, we had a DEXA scan taken and a CT scan of the hip and knee. Throughout this year, they were treated monthly with a subcutaneous injection of romosozumab. At month 3, they received just a DEXA scan follow-up, and then at months 6 and 12, they received both the DEXA and CT scan again for comparison. For today, I'm just going to focus on DEXA results. As I mentioned, this trial is currently in progress, so I don't have full CT results for you yet today. So here we can see overall, generally at the lumbar spine, total hip, and the femoral neck of the hip, there is a significant change over the year of the clinical trial. You can see general trends. So we have the p-values here. General trends, the bone mineral content and bone mineral density are increasing at each of the locations. To make things a little bit easier for you, apologies, this slide did not transfer well from computer to computer. So these graphs look a little funkier than they're supposed to, but these are percent change graphs from baseline. So first year we have DEXA-derived aerial bone mineral density at the lumbar spine. The thin lines are the individual data. So you can see that pretty much everyone is experiencing an increase in bone mineral density at this location. This graph has the average line, but it's missing the 95% confidence intervals, and they look a little funky on this other one too. Sorry about that. On the other side here, we have aerial bone mineral density at the hip, little less ideal, I guess, than the lumbar spine. We have a few people that have minimal change and then some with a bit more change. But in general, we are seeing a significant increase in aerial bone mineral density at the total hip as well. These results are very comparable to results in postmenopausal osteoporosis with drug treatment with romosozumab. We've seen in previous literature about a 17% increase in BMD at the lumbar spine and 5% increase at the hip in the postmenopausal trials. So very similar here. It's about 11% on average at the spine, slightly smaller at the hip, around 5% or 6% as well in our sample. So in terms of continuing with this clinical trial and some next steps, we have seen that initial CT analyses suggest more change in trabecular than cortical bone with regards to these increased trends that we've seen. This is a very small sample size, I believe 6 or 7, and it's not complete yet. So we are still working on that analysis. So I will continue in the near future with the analysis of the CT mineral content at both the hip and the knee. And then we'll proceed into the finite element analysis. That will be similar to the analysis used in the zoledronic acid trial. Generally speaking, while this study is not yet complete, we can say that these DEXA results show some promise for romosozumab treatment in chronic spinal cord injury. Again, this is limited to a sample of women with an average age of 45 and injury duration of about 15 years. Just to finish up and sort of bring back the 3 studies all together, some takeaway messages. The standardized bone health education following spinal cord injury may be beneficial for patient care. So we saw that information on prevention and treatment options were an express patient priority. So again, based on our sample, definitely a research priority to continue with. Zoledronic acid administered during acute spinal cord injury is safe and effective treatment to mitigate bone loss and reduce fracture risk, regardless of one's ability to ambulate following injury. And romosozumab may be beneficial in increasing bone mineral density at the spine and hip during chronic spinal cord injury. But as I said, this study remains in progress. You can stay tuned for more results in the next 6 months or so. Before I hand it over, just wanted to thank my supervisor, Dr. Brent Edwards, my committee members, Dr. Greg Klein and Dr. Lee Gable, as well as the co-authors on some of the papers that have recently been published. We had some collaboration with the Restore Network here at the university, as well as colleagues at Northwestern University. Funding sources, including the Eyes High here at the U of C, which funded my PhD, as well as the other members of the Edwards Lab.
Students in the class? No? Okay, I'll start off the discussion. So how long, actually I'll start with this one. So when was the zoledronic acid treatment started in these patients, and does it seem to be like a sweet spot or a window in which you need to start it to be most effective?
Yeah, so the definition of chronic spinal cord injury I've found can vary, or sorry, acute spinal cord injury, pardon me. The number of days can sort of vary depending on the researcher and the publication. I believe for this, you had to start the study within 120 days of the spinal cord injury. And I think the average duration was somewhere in the 60-day range, 65-day since spinal cord injury took place. So this would be all considered the acute phase. In terms of a sweet spot, I don't know that I can like narrow down a specific amount of days for you, but we do know that the most rapid bone loss is in that first 2 years following injury. Most of the studies that successfully mitigate bone loss, you're looking more towards the 60-day mark, like we had in our sample size. Furthermore, the first publication for this clinical trial, I didn't go into the 2-year duration, but it was a little complicated and a lot for one presentation. But in the second year of the study, the groups were split further. So at the first year, it was Zol and placebo. And then these groups were split further to see like Zol, placebo, placebo, Zol, or sorry, placebo, placebo. And the treatment group that received placebo for the first year and then Zol for the second year was not statistically better at the hip or knee than those that received placebo, if I'm not mistaken. I think that I have that right. So that tends to suggest that, that waiting that extra year was too long in a way. So hopefully that can suggest a window there. I don't have an exact date, but yeah.
Other questions?
Hi. I was wondering, for women with chronic spinal cord injuries, as they transition kind of into menopause, do they have this kind of like double hit effect where they have this further large decrease in bone mineral density?
Yeah, that's a great question. I think that there's different ways to look at it. If when we talk about bone mineral density loss due to spinal cord injury, the magnitude of bone loss like exceeds, tenfold the loss potential due to menopause. So I think that it's important to highlight that, this substantial bone loss seen due to spinal cord injury is much more than we see due to menopause. So I think it might be a case-by-case basis in a way as to how much further reduction you would see during that menopause phase as well. But I think it's definitely a consideration, especially when we're looking at the treatment. So for example, the Romo study that's entirely in women, and their average age was about 45, definitely something for us to look at if there's any sort of case-by-case basis with that transition to menopause. But for sure, just in terms of magnitude, like the magnitude of bone loss with spinal cord injury way exceeds the magnitude due to menopause.
Okay, question. And does spinal cord injury, does that cause osteoporosis, or does osteoporosis cause spinal cord injury?
Okay, that's a good question. In terms of what we're looking at, it's really the spinal cord injury causing the secondary osteoporosis. So primarily the mechanical disuse following injury, so from the paralysis is what's causing, like I was saying, this very drastic decrease in bone mineral density that way exceeds, menopause or even space flight. So it's in that sense, it's very much the spinal cord injury causing the secondary osteoporosis.
The last study in the drug treatment group, I'm wondering about in a control case, does the bone growth occur everywhere, or does it occur at load dependent places of the body, like where if you exercise more your particular joints to grow more there? I just don't know how broad the drug works. So. Yeah,
that's a good question. So typically in the literature, we're seeing the highest effects of drug at the lumbar spine. So this could be the highest effects would be lumbar spine, and then hip and knee would be lesser than the lumbar spine. Still working on that analysis, so I can't say for sure the results in our group. There are exercise interventions with spinal cord injury, like functional electrical stimulation, and some studies will promote both, like using both pharmaceutical and FES in combination for treatment types. I think I couldn't speak to the full body of literature, but typically that's talked about quite a bit at the hip, being beneficial to have both the FES and a drug treatment. Haven't seen that specific to romosozumab, but different bisphosphonates. So I don't think there's like a general consensus that way with adding exercise with drug treatment, but there does seem to be literature saying that can help in improvements at the hip.
It looked like you had one big outlier, and it was that.
Yes.
Do you think that's real, or is that? Or do they
Yeah,
do something different exercise, or any speculation?
I don't have speculation now on that outlier. I think that in the next few months, when I start to look more at the CT scan, the analysis, we can talk more about, is it the trabecular? Is there something different in this participant in terms of the amount of trabecular and cortical bone gained versus the other ones? Also, definitely we'll look into the other information regarding that participant. So I haven't looked at this participant yet, but for sure, taking that next step from the DEXA scan to the CT scan, those CTs do provide us a lot more information regarding the different constituents of bone. So that does provide us some flexibility to investigate further on that for sure.
I have a few questions right here as well. In general, my question is, how far could you, in principle, go with an improvement in these measures?
Like a maximum value?
Yeah, like, I mean, at least if I were to follow, let's say, the average regression line, like how far can I go? Like, does it plateau at some point?
That's a good question. I think so. Unfortunately, as I said, like romosozumab is a fairly new treatment type. So the body of literature on romosozumab isn't as big as some of the bisphosphonates that we've seen. So I don't have an exact number for you of when a plateau might occur. I think that it is promising that our results mimic quite closely what they've seen in postmenopausal women. So considering their gain at the lumbar spine, for example, is about 17% in clinical trials. So that's giving us maybe an indication of a value there. I don't know already like where we would start to plateau. There is some literature because romosozumab has these two effects, like the anabolic and anti-resorptive effect as a drug. So it reduces bone resorption and also helps bone building. There is some literature that has talked about after the first year, the treatment type mostly starts to have more of the anti-resorptive effect and less of the anabolic effect after a year. The body of literature is pretty small, so I've seen that in a couple of papers. So that might help instigate a plateau, but I'm not too sure.
And then, I mean, like in case of this, let's say putative outlier, did they maybe also like start very low compared to the rest of the group, but then ended up at the similar level?
Yeah, that's definitely a possibility. I don't have the exact numbers for this outlier, but it's certainly a possibility that whenever we're looking at percent change, and actually I don't have the raw data on this slide either, it's averages, but whenever we're looking at percent change, it's something you have to be aware of. Of course, the size will look quite a bit greater in those that started with a smaller value. And that wouldn't be the first time we would see something like that in the clinical trial results for sure.
One other question. So what if you were to give this drug to a healthy person? Would they also have improvement or like changes in bone mineral density?
That's a great question. It's a little bit hard to say. I think that most likely there would be some improvements. I don't know if you would necessarily see a magnitude of change as you would in either the postmenopausal osteoporosis group or the spinal cord injury group. But it is, the drug is inhibiting sclerostin, as I said, which sclerostin itself is an inhibitor, so that leads to bone building. And we do see that in individuals who have totally like different diseases apart from this research, but people who are born with diseases that affect sclerostin, they can have really, really high bone mineral density and content levels. So because we're seeing that in sort of a disease that occurs naturally, my guess is that if you were to administer this drug in a healthy population, might not be as extreme, but you might see a trend that way as well.
You showed an effect from the drug treatment and an effect from the change in whiskey score. And I'm wondering, are those two effects additive or are they multiplicative?
That's a great question. So from a statistical point of view, they were each independent predictors, but the three-way interaction term was not statistically significant. So if you did like treatment group by time by change in whiskey, it did not have a significant three-way interaction. So I'm tempted to say they're not multiplicative if I'm interpreting that correctly. The other thing to kind of consider with the way that we've categorized the change in whiskey score is that that's a clinical measurement tool. It's not necessarily indicative of how much loading they're actually doing, right? So it's a diagnostic criteria that we're using in the clinical trial. It's not sort of the same as if we would have put, in theory, maybe like an activity tracker or tried to track the volume of activity they're doing day to day, which would be very different in each individual. So I think maybe in that direction of thought, I would need more about, volume of mechanical loading that is happening for each of these individuals. So the whiskey score it's a valuable clinical tool, but it's also not capturing all the sort of bone loading volume that we could capture with another tool.
So I can't remember, how much data do you have? Because one thing I would suggest is if you have enough data, maybe you can do a regression along the whiskey instead of having it in 2 bins divided by difference of 4, but you could, it's like almost a continuous variable. So you could do a regression, and then that would make it easier to detect a multiplicative effect.
Yes, so for the stats, I did use a linear mixed effects model as it was a continuous variable. It was just for that visualization that I binarized it. I didn't actually binarize it for the statistical model. It was really just to give a visual. Yeah.
Thanks, Laura. Yeah, really interesting data. And with the Romo 6, so these are chronic SCI. So they've been, was it 15 years?
Yes, on average.
So they've already lost presumably as much bone as they will lose.
Yes.
How does this sort of change compare with other drug treatment? Like this is a really large increase after.
Yes. Yeah. So in terms of in the chronic spinal cord injury, I would say on the whole, the body of literature in chronic spinal cord injury drug treatment is less than acute, first of all. In terms of the previous study that Brent did with the colleagues from Northwestern, it was teriparatide that was used. So that's an anabolic agent. And the results were certainly not definitive. Like they didn't show a significant increase.
Yeah, didn't show anything.
No, yeah. Yeah, so this would be certainly an improvement compared to teriparatide.
And then in terms of like long-term management, presumably people have to stay on Romo?
Yeah, so in the bisphosphonates, there's a little bit more literature on, the starting on something like zoledronic acid or alendronate and like following for 3 years, making a clinical decision as to continue. For Romo at this point, I'm not able to say anything about like rebound or in this type of population. So ideally, I don't think when you're talking about someone age 45 was the average, the goal would not be to keep them on romosozumab for life. That's a long duration. There's other risk associated with that. But I don't really have a good value for you as to how long to keep them on romosozumab or what a transition plan would be at this point.
Can I comment on that?
Yeah.
And the simple answer is it's actually only FDA approved for 1 year.
So then are you following them to see what's going to happen in the
Yes.
next
We're
year?
giving them, well, they're all getting it. They're
Alendronate.
all gonna get alendronate.
Yeah.
And then did you look at the change in T-scores? Like, are they going from like diagnosed osteoporosis to healthy range, or are they just moving up into like a low bone mass or less osteoporosis?
Yeah, that's a great question. I don't know why I didn't. I did not assess T-score before this. I've been doing just the aerial bone mineral density, but I absolutely will look at T-score as well.
I do take issue with exercise in a syringe. No, well, and we can talk about that later, but there's no change in any muscle properties, and presumably the risk of a fall would not change at all.
For bone, it's like, don't take it so seriously. It's the weak pathway. It's the same pathway that people think that mechanical loading influences bone.
But these are really, really neat findings.
Thanks. Yeah.
I'm not overly familiar with the spinal cord injury population, but I was curious about the ambulatory results that you showed. You showed that there was almost this fairly a larger increase within the first 6 months, and it almost seemed to plateau.
Yeah.
Between 6 and 12. Is that a typical response in spinal cord? Like, are you going to regain as much motor function as you typically will within those 6 months, or is there any like
Yeah, so maybe I'll just go back if I can really quickly. So just to like remind that most of the participants were actually a score of 0 and stayed 0. So while there are a fair number that did improve, the majority or the largest percentage at a single score was staying at 0 in both the groups. You're right, there is like a steeper increase in the first 6 months for those who did improve. I'm not super familiar with like full trends, but I think that in terms of the acute phase, I think that there is definitely a lot going on in that initial phase of spinal cord injury. So once you kind of get past that 6 months, or I guess what I should say is it's very tough at the beginning when you have all these clinical factors contributing to have a high whiskey score. I don't know if once we get past the year, there's much room for improvement past there. My guess is not a ton. But I don't have too much expertise in like trends of whiskey score over time.
And just to follow up, do you know if the ones that did have that larger increase within 6 months, are they associated with a different level or its type?
Yeah, definitely. I don't have like specific numbers for you here today, but for sure with the discrepancy between like motor complete and motor incomplete. So in this study, the vast majority of participants had a cervical spinal cord injury. So that was the high anatomical locations that were complete. So that was what we tended to see in this population, just based on the differentiation between a complete injury and an incomplete injury. We would certainly, in general, expect to see a bigger recovery or bigger ability to regain functioning in a motor incomplete injury, where some of the motor functioning and sensory function is retained or regained below the level of injury. Yeah.
I'm going to go back to the zoledronic acid. Something I'm curious about this. You said within 2 years, that seems to be the period where there's the most rapid bone loss.
Mm-hmm.
I know you haven't done this, but just to speculate, how long do you think you'll have to take or be used with zoledronic acid beyond or after your spinal cord injury?
Yeah, that's a great question. So something I didn't touch on today is that long duration of bisphosphonates are sort of associated with other risks as well. And that goes for in the spinal cord injury population and postmenopausal, just in general with osteoporosis treatments. There are different risk factors that can increase, like atypical femoral fracture with long-term usage of bisphosphonates. So definitely duration of treatment is, I don't know, a hot topic for lack of a better way of saying that. So in this case, if we were to take them off of zoledronic acid, we certainly would see a decrease, in my opinion. Like the zoledronic acid has some effects where the way that it's worked, it's absorbed into the bone and there is some slow release. So if you did stop taking it, you would still see some effects over the year or so following it. But if we took them off zoledronic acid, you would definitely most likely see decreases again in bone mineral density. That would be a case-by-case basis, I think, depending on how much ambulation they regain, how much mechanical loading they're doing in the years following. But I don't have an exact answer of how long you'd have to stay on it. Typically in postmenopausal women, zoledronic acid treatment is sort of reassessed after every 3 years or so, because it does have these other side effects as well. So complicated topic and definitely hot in literature and research right now.
There's no final burning question, but I have one, and it's again out of curiosity. So you mentioned that you gave an example about how spinal cord injury patients get a fracture in their foot or leg. But how do they, like, what is a common incident for how these patients are fracturing like their femur or their spine? Is it through transfers or how?
Yes, so transfers would definitely be a big one. So there's a number of different ways to transfer someone with spinal cord injury from like a wheelchair to a bed, for example, or to another chair. And a commonly reported injury case is a fall during a transfer. I would say that's probably the most common that I've come across.
Okay, so it's more like a traumatic or more of an impact.
Yeah, it depends what you consider the definition of a high impact, I guess, because I think a like sort of basic definition is often from a fall from height of your body height or higher to be a traumatic. So I think there's like a little bit of discrepancy on for a fall, what would be considered high trauma or low trauma. So technically, if you're being transferred out of a wheelchair onto a bed, for example, depending on the definition you use, I think that could still be considered a low trauma or low energy fracture as well.
Interesting. So let's thank Laura for the talk.